Welcome to the Division of Continuing Medical Education's Post-COVID-19 Condition Winter 2025 webinar series. The presentations will be delivered in English, but French captions will be posted with the recording after. As we gather here today, we acknowledge we are on Treaty 2, 4, 5, 6, 8, and 10 territories and the homeland of the Métis. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. So we have a quick poll now, just to find out who is in the audience. So this first poll is going to come up on your screen. So if you can just select your role from this list, and I'll give you a little time to do this. Thank you for participating in this. So I can see the majority of our attendees today are patients with post-COVID-19 condition. And then we have public family members as well. We have some physicians, a good number of nurses and allied health professionals, and we have a few pharmacists and researchers as well. The second poll is about knowledge level. So this will come up again on your screen here. And if you could just rate your knowledge level about the following PCC topics. Thank you again for participating in the knowledge level poll. So I can see for the impact of PEM symptoms among patients with post-COVID-19 condition and their families, we have between low to high. So pretty even between low to high. For the diagnosis and management of PEM symptoms, again, low to high. And then CAN-PCC guidelines, low to moderate. Thank you for participating in those. This session is accredited. Following this webinar, you will receive a certificate and evaluation form. The recordings will be available after the series. If you have any questions, please post your questions in the anonymous Q&A function or with your name visible in the chat. During the Q&A, you can also raise your hand and unmute. And these are the steps we have taken to mitigate potential sources of bias. So without further ado, these are our speakers for today's webinar. We have Sophia Fornwald. She's an exercise physiologist and therapist at Stapleford Health and Rehab. She's on the Recover team, and she's part of the Canadian Society for Exercise Physiology as a clinical exercise physiologist. And she has a special interest in chronic disease management. And then we have Derek Bisaro. He's been practicing for 10 years as a physical therapist at Stapleford Health and Rehab. He has a diploma of manipulation and is a fellow in Canadian Academy of Manipulative Physical Therapists. He's also certified in intramuscular dry needling and is also on the Recover team. He has a special interest in craniofacial pain and TMJ. And last but not least, Lindsay Roysum. She's an occupational therapist at Stapleford Health and Rehab. She's been practicing for 18 years and she's a concussion rehab specialist. She's also certified in cognitive behavioral therapy for insomnia, and she has a special interest in autonomic nervous system regulation. She focuses on creating healthy habits and routines that support people's goals. So thank you to our three speakers for joining us today, and I will hand it over to Derek.
Okay, thank you. So we're doing our talk on post-COVID-19 condition, post-exertional malaise. None of us have any association from a financial perspective, but we are all receiving honorariums for participating today. So by the end of today's presentation, learners will be able to explain what post-exertional malaise is and how it relates to the post-COVID-19 condition. Should be able to identify symptoms that patients will describe when describing post-exertional malaise, identify the importance of screening for post-exertional malaise, as well as understand the management of post-exertional malaise informed by practice and CAN-PCC guidelines. So a little bit about us. So we work at Stapleford Health and Rehab in Regina, Saskatchewan. It's a multidisciplinary private practice rehabilitation center. We do have a primary focus on musculoskeletal conditions, but we do have some other programs, including the Recover program. We launched the COVID Recover program back when we got back to work after the pandemic in 2020. Initially, the population of people that we were treating had fairly severe COVID-19 infections and many requiring ICU stays. But as time went on, we started getting referrals from people that were unable to bounce back, or maybe they did initially and crashed. And this is when we started hearing about the COVID long hauler syndrome, and which is being described as now post-COVID condition. And we're doing a talk today on post-exertional malaise. So post-exertional malaise, I really like this definition of it. From just doing the scan of the research from when I was looking for this presentation. But the authors, Nakul et al. From 2021, described PM as a perceived exacerbation or some or all of the symptoms of myocarditis, chronic fatigue syndrome, or long COVID after physical or cognitive exertion. PEM is described as a disproportional worsening due to the physical or cognitive effects that were previously well tolerated, typically with a delayed onset, and these exist often for extended periods of time. Patients reported or report inexplicable, incapacitating, persisting, or relapsing fatigue, unrefreshed sleep, difficulty with cognition, as well as musculoskeletal pain that heavily impacts patients' lives. Post-exertional malaise can be triggered by physical, cognitive, mental, social, or emotional exertions. And this most importantly, varies significantly different person to person. The worsening of the symptoms can be due to exertion that can happen effective immediately after the triggered activity, or it can occur 24 to 72 hours after exertion. And this can make it very difficult to predict and manage people's symptoms, as it can take days, weeks, or months to recover from an episode or exacerbation. The exhaustion caused by this exertion can be very disabling, and it can affect different areas of the body. So a very holistic approach is quite important for this. And post-exertional symptom exacerbation is a feature of the inability to produce sufficient energy on demand, and is characteristic along those with myalgic encephalomyocarditis or chronic fatigue syndrome. One of the biggest and most important parts of post-exertional symptom exacerbations, these can be triggered by different things. So it's very different person to person, and it's quite commonly usual activities of daily life. So this can be something like changes to sound or light or other stimuli, or other just basic activities of daily living that people were able to tolerate previously. It is not the same as a boom or bust cycle where you get too overactive and then you have a big response, and then you kind of can go back to it because it happens as a delayed effect. It can be triggered by overactivity, but it's not just overactivity. It can be something simple like showering or fluorescent lights or getting dressed, walking. It's really individualized for this. So it's patients are quite frustrated by this typically, because they usually find that people don't hear or understand what they mean when they say they're tired, because it's not just by being overactive.
All right, thanks, Derek. We'll move over to me now. The CAN-PCC just wants us to go through kind of what they mean by strong or conditional recommendations, because as the recommendations are coming out, they have conditional recommendations and they have strong recommendations. So for patients, if it's a strong recommendation, people will want to follow it, but a small proportion might not. If it's conditional, most people would want to follow it, but many would not. Most people, if it's a conditional recommendation, you might want to discuss it with a health professional first. For healthcare professionals, if it's strong, you would want to prescribe it. Adherence could be used as a quality criterion or performance indicator, but decision aids aren't likely to be needed. So it's like, this is strong. We're going to follow it. Of course, follow up with our patients on this recommendation and how it's working for them, but we want to try it. But if it's conditional, you likely would want to prescribe it, but knowing that choices are going to be appropriate for different people, you might want to use a decision aid as to, does this work for your particular patient? And for policymakers, if it's a strong one, we want the policymakers to adopt it in most situations, versus if it's conditional, there will require substantial debate and policies are going to vary a little bit more. Just want these recommendations to help inform the policymakers. So when we look at post-exertional malaise and post-COVID-19 condition, we find that post-exertional malaise is often described in clients who have post-COVID-19 condition. And I don't have a prevalence rate of that, but most of the clients that we see definitely describe post-exertional malaise. It can be a symptom, but it's not necessary for a diagnosis to occur. And there are questionnaires that can be used to screen for post-exertional malaise, and it can be helpful in actually understanding the symptoms or the treatment. So the CAN-PCC collaboration suggests the use of questionnaires to screen for post-exertional malaise over not using them. They're like, yes, we want you to use them versus not use them in adults where you suspect the post-COVID-19 condition. The DePaul symptom questionnaire was examined in the recommendations and is recommended to be used by the CAN-PCC. So the actual recommendation is there written, and it is a conditional recommendation. So what our clients report. So I just kind of took some general quotes from different things our clients have told us when they're describing their post-exertional malaise. I went to the grocery store. I ended up crying in the checkout line. I was so exhausted. I couldn't even pay for my groceries. My friend had to help me and then walk me back to the car and deliver me and my groceries home. Sometimes I feel good in the moment. I'm okay. I feel normal. So I go out to a social activity and something that seems like normal things to do. And then the next day, I can't get out of bed, and this lasts for 2 days. I'm okay until I'm expected to use my brain, like make a list or problem solve, and then I need to go to bed. I'm physically tired from making a simple to-do list. So I think that that captures a lot. Those quotes kind of capture a lot of what our clients are saying. It's like Derek mentioned, it's not because, oh, I ran a marathon and now I'm tired, or I, cleaned my entire house and washed all my walls and vacuumed and everything, and now I crashed. It's like I went to the grocery store. I thought I was fine. It's these simple things that can be triggers. So how do we assess this functionally? Well, we start with subjective questions and start asking, as people tell their stories, we start really asking more, diving into it. You report being really tired and crashing. Have you noticed any common activities that precede the crash? What activities seem the hardest? Or are there any activities that if you do, you will end up in bed? So what are some common triggers for post-exertional malaise? Honestly, they can be anything. It's anything your nervous system perceives as stress. So sometimes that might be exercise, physical activity. It could be stress. I had a client that saw a car accident. She wasn't in a car accident, but she saw a car accident, and that stress was enough that then she had to go sleep for the rest of the day. Sometimes eye movements are big triggers for a lot of our clients, or moving their head too fast. So that like vestibular stimulation. Light and sound are really common triggers. Driving can be a trigger. Problem solving, anytime you have to break some problem down into multi-step tasks, that can be a trigger. Reading, even digesting food can be a trigger. So it's really all over the map and really individualized in people's experiences as to what their triggers are. So what do we do to actually help find the triggers? I use an activity journal with my clients. I find that really helpful. So I get clients to journal their entire day and rate their symptom levels throughout the day. It is an energy sucker, and it might be a bit of a trigger. So we have to be careful with that and the amount of detail we want or things like that. I try to keep it really basic. but we really do need to start tracking what they're doing in their symptom levels so that we can do the detective work of what their major triggers are. And then we can make changes in their daily routine and see, did that affect their crashing? Did that affect their post-exertional malaise? And it gives us a larger opportunity to really look at in depth at their daily routine and what their self-care looks like. Like, are they not getting any of their self-care because they're crashing so much that they can't even take care of their basic needs? And another note is that, as Derek mentioned, post-exertional malaise can be triggered 24 to 48, or I think he said even up to 72 hours after an event. So journaling helps give us that data to figure out. So we really have to look over the time span of the week as to what your triggers are and when, and to try to find those. And it can be really tricky to figure out. So the activity journal definitely helps us with that. We really work at trying to plan our day for people who have post-exertional malaise once we've kind of found what the triggers are. This is a planner that we created here, but there's many different ones on the internet or at the dollar store or whatever that people can use, or just a piece of paper is fine, just to help with pacing, goal setting, and managing your day. We try to have consistent wake-up times, activity times, and rest throughout the day. And it's really individualized depending on where they're at with function. So, some people, we just might have, no more than one activity a day. And other people, I've started them off, and by an activity, I mean an appointment, maybe an outing, a social activity, anything like that. Anything outside of our self-care could be an activity. And it's like we want just one a day. Or with some people, we look at where they're at and we're like, okay, one activity every other day. Let's try to build in. And we might build parameters around that, what activity looks like. But where we can start is really individualized depending on the person's function. And we start really teaching what rest can look like. And we work on things like body scans, meditations, and other present-minded techniques and forms of rest. So if you were in my brain fog presentation, I apologize if some of this is a repeat, but really we need to regulate our nervous system to help with both brain fog and post-exertional malaise and managing any type of chronic condition. We have to get our nervous system regulated. So we build those types of rest in that also regulate ourselves. And then we sandwich our triggers with these down-regulating activities. So they don't have as much a crash effect on the person. So if we can kind of first down-regulate, do a bit of the activity, down-regulate again, deep breathing, those types of things, so that it doesn't have that huge impact on our nervous system as like, oh my gosh, this is a stressor. We spend a lot of time educating about pacing, and the activity journal helps with that. And like I said, we schedule in rest. So I kind of already talked a little bit about how we address the triggers, but just as an example, if a trigger is light and noise, maybe we choose a store to go to that has less light and noise. Some places like Safeway have quiet shopping hour where they dim the lights. They don't do any intercom things at that point. It's a quieter shopping time. And so maybe we start with that. We choose that first. And then maybe we have someone drive us to the store to decrease our cognitive energy of getting to the store. Then when we get to the store, before we even get out of our car, we do focused diaphragmatic breathing for 2 minutes. Then we go into the store. We focus on present-minded techniques when we're in the store, where we're really grounding ourselves while we're walking through. And then we return to the store and do another round of diaphragmatic breathing. So we're trying to take that fight or flight response really away from the experience of going to the store, if the store was a trigger for someone, and to try to make it so it's not a trigger. And then, like I said in this slide, we are also trying to build up energy in people And rest, meditation, focused breathing, grounding, acupuncture are all examples of things that we found. Massage for some people that actually help build energy and build their capacity and their tolerance to these triggers of post-exertional malaise. So how do we actually increase the activity level? So using an active rehab approach, we're going to progressively expose ourselves to the triggers, but not let our symptoms climb too much. I use like a 10.6 scale for symptoms, and we have people not increase their symptoms by more than 3 on a scale, just to give them some context or guidelines. So if you're already sitting at a 9 or a 10, you're not going to expose yourself purposely to something you know is a trigger. But say you are at a 4 or 5. So we expose ourselves to that trigger. Don't let our symptoms climb up to more than a 7, and then we come out. And Sophia will go more into the exercise portion of this, but really we kind of use that idea in the gym as well, is where can we expose you? Can we let your symptoms climb a little, but not too much? And this is really individualized. It's going to be different for everybody and what their tolerance is going to look like. So it has to be tailored.
The CAN-PCC guidelines suggest using rest pacing for adults with confirmed PCC and post-exertional malaise. Cognitive behavioral therapy, in addition to pacing, is conditionally recommended in people with PCC and post-exertional malaise. CAN-PCC recommends exercise for those without post-exertional malaise. However, at this time, those with post-exertional malaise are recommended to only exercise in the context of a research study. Recognizing the health consequences of the lack of exercise, we refer to the good practice statement of creating an individualized care plan with a healthcare provider.
So I'm Sophia. I'm the exercise physiologist working with the COVID Recover team. Currently, at the time that we were putting these presentations together, there was no CAN-PCC guidelines for physical activity and exercise. So I really want to speak to our program and what we have seen to be successful in the exercise component and how it's helped in the management of post-exertional malaise. So our exercise programming for PCC does not apply progressive overload, but instead is guided by individual activity threshold, as Lindsay spoke to, and individual response to activity. The international guidelines from public health organizations, including the World Health Organization, caution against graded exercise programs when dealing with PCC, and especially in those with post-exertional malaise, as it could cause that crash or exacerbation of symptoms. So our exercise assessment is critical in establishing baseline functional status and individual limits for physical activity. These limits would specify the intensity, frequency, and duration that can be performed of activity without resulting in a crash. So the client and I will have an in-depth conversation about what they feel they're physically capable of doing without triggering a flare-up of symptoms, as well as we'll use some outcome measures that they can fill out on the initial intake that'll guide the exercise prescription for both aerobic and resistance training. So we set individual thresholds for heart rate, rating of perceived exertion, that 10-point scale that Lindsay was referring to, their metabolic equivalent of task setting, and we can measure lactate levels as well in the gym. But these are all used to guide the intensity and the prescription of exercise. But the most important threshold that we'll use is their day-to-day reported symptoms, as well as that kind of baseline that we've established. So if somebody's coming in and they feel that their energy levels are incredibly low that day, we might not perform any activity, or we'll keep it at a very manageable level that we know that they're able to tolerate. The exercise program's sensitive not just to the physical triggers of post-exertional malaise, but also the sensory, emotional, and cognitive ones as well. So we try to work with the client to make sure we're minimizing any external environmental triggers, having that malaise after the exercise session. So for example, Lindsay mentioned some clients are sound sensitive. So we do start, in a private room, maybe with the lights dimmed, with minimal noise exposure, and then try to slowly build up that tolerance until we're able to enter the typical gym setting. So the main goal of the gym is to build up resilience. And we do this slowly over time. And that just means to improve an individual's tolerance to physical triggers, as well as some of those cognitive or other exertional ones, so that the intensity of a crash is less and the recovery from a crash can be quicker. Gym programming aims to slowly do this and build up functional capacity over time so that this person can return to their activities of daily living or other established goals without experiencing that post-exertional malaise. Research by Appelman and others states that individuals with post-COVID condition have a high potential for mitochondrial dysfunction, and this may contribute to some of the intolerance of physical exertion. And Molnar and others said that the function of mitochondria is essential for maintaining cellular and systemic homeostasis. Any disruptions in mitochondrial function can lead to a decrease in energy production, increased oxidative stress, and initiation of inflammatory pathways, all of which could contribute to the pathophysiology of post-COVID condition. So we know that aerobic activity helps to improve mitochondrial function. By increasing the number of mitochondria within cells, it enhances their oxidative capacity, so that oxygen uptake, and it promotes the creation of new mitochondria. So Mamey and others stated that exercise remains one of the most potent behavioral therapeutic approaches for the improvement of mitochondrial health, not only in muscle tissue, but it could be found in other tissues as well. So by applying a tolerated amount of aerobic and resistance activity, we've seen improvements over time in the intensity and the frequency of post-exertional malaise in our clients. And that essentially helps to build up their resistance. In our program, not only have we seen physical improvements, but also psychological ones as well. So many of our clients come into our clinic and they're feeling quite low and quite merciless to their symptoms, and unsure how they're supposed to get better when, the smallest things might trigger them. Exercise, even in little bouts, small tolerated bouts, can provide a healthy coping strategy and provide both physiological and psychological benefit in mental health and well-being. For example, exercise does help increase blood flow to the brain, which can help aid in cognition. It releases happy hormones, helps to reduce inflammation, and provides nervous system regulation, which in turn can boost the immune system. All of our exercise is monitored and adjusted based on individual symptoms, and it's tailored towards what that person's able to tolerate. Fit principles and other thresholds to guide the exercise, but the most important would be their individual rating of perceived exertion, both while in the gym and after. Essentially, use it or lose it with managing your physical fitness. So even when you're experiencing post-exertional malaise, not performing any aerobic or resistance training can lead to a further decline in health and functional status and worsening of comorbidities. Exercise is especially important to help manage the diagnosis of chronic conditions and comorbidities like hypertension, diabetes, cardiovascular conditions, mental health, and those blood pressure changes. So not performing any activity might lead to a worsening of the experience of post-exertional malaise. So the exercise prescription and post-exertional malaise, what that looks like is it's very individual. So each person will get a prescription of resistance exercise. So that's that strength training. We're doing a lot of nervous system regulation, like breath work. We're performing tolerated amounts of aerobic activity. And we're, trying to build them up and build that resilience. We'll monitor thresholds while they're in the gym. And we do consider dysautonomia as well. So many of our clients with post-exertional malaise also present with other autonomic dysfunctions, so particularly POTS or those other sensory things. So we're trying to keep that into consideration when we're prescribing exercise. As mentioned, it's not a linear progression. It's very guided based on what that person can tolerate and when we're able to progress, the duration or the intensity. So we're not following a progressive or graded exercise program. And we work closely with the occupational therapist to kind of figure out when exercise can be applied to the schedule and into that routine so that we're supporting their minimizing of those symptoms and minimizing crashes with their schedule. And of course, we'll monitor symptoms throughout the exercise program. Just a note on dysautonomia, because many of our clients present with other conditions associated. They've found exercise to be super helpful in managing postural orthostatic tachycardia syndrome, and even more effective than some drugs. So exercise has been really helpful in terms of managing post-exertional malaise, in addition to those other comorbidities that people come into the clinic with. And so there's a CAN-PCC recommendation for post-exertional malaise that suggests not using central nervous system stimulants for individuals with post-COVID-19 condition and brain fog, with or without post-exertional malaise. Reference this as well.
Thank you so much for presenting on PEM today. So we'll go to the Q&A period now. So I can see we have questions in the chat here. I'll start going through those and presenting those. And Sophia, Lindsay, and Derek, if you can just jump in and answer those, that would be great. And please keep posting your questions in the chat and I'll keep going through them. Remember, you can also raise your hand and unmute when called upon. There was a comment by Anne that there might be a typo in one of the slides, so we'll definitely double check that before we send the slides out. Thank you, Anne. We've got a comment from Christine Bryant, who says she agreed. She said, my OT and doctor say I'm doing too much, which I am not. And then a comment from Anne saying DSQ PEM is very useful, but it's not been developed to screen for PEM in general. It may be hard to interpret for unfamiliar clinicians, and also the threshold of activity is very low, so it may miss people with PEM that have a higher threshold. The screening questions from the US ME/CFS Clinician Coalition are very useful in a clinical setting. And Anne's just added a link there, a PDF. So thank you, Anne. Sue has a question about the daily planner. Would we be able to get the daily planner to send to everyone attending today's webinar? Is that something we could do, Lindsay?
Oh yeah, if you can send it out to everyone, then yeah, I can send it to you. Absolutely,
yep.
That's not a
Perfect.
problem.
So yeah, we can get that sent out today. And then Lindsay's made a comment, for relaxation, yoga nidra has been the most useful for me. It's not actually yoga, it's similar to meditation.
Yeah, with a lot of clients.
And then Lorraine says, what suggestions do you have so we can educate long-term disability insurers and our employers about the reality and consequences of PEM? The lack of understanding is costing employers, insurers, and patients much.
Yeah, I agree, Lorraine. I think just as medical professionals, we need to do our best in educating the people around us. So when we have people on long-term disability, providing that education, and if it's coming from the whole team, the doctors, the specialists, and the rehab professionals, I think that is helpful. The more they hear it from a more variety of ways, the better. So that's just part of our own client and patient advocacy. The whole goal of these webinars is to help spread that education. So maybe, sending some of this information and sending some of the CAN-PCC things out is helpful.
The other piece is generally, especially for long-term disability coordinators, they're quite often not medically trained. So it's very commonly something that they're coming in from an insurance perspective, but not from a medical perspective. So it's usually what I find is the best is to have the patient encourage the disability case manager to reach out to the treatment team so we can have an actual conversation with them. And again, it goes back to it needs to be an individualized thing because sometimes, like, if you get a handout on something that you don't have any knowledge basis on, you're going to do this and then file it away and not do anything with it. But if we can actually have a conversation, explain and say the literature says this, 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 and this, then it's a lot more effective strategy. So usually my general recommendation for people in that situation is your long-term disability person that is a long-term disability person. They're not a medical person. They usually need to speak with your medical person that has your back and has the understanding of things.
Thank you for that. We have a question from Sue. She says, my question is about addressing triggers and increasing activity level. Do you use this for return to work as well?
Yes, we definitely look at the triggers for return to work, and we look at the triggers for the schedule, the return to work schedule. So some people some people were just doing exposure to the workplace, knowing that it might be a trigger. So maybe the first month is they're just on an exposure. So they're going 2 to 3 hours a week into the workplace before we even start a return to work, just depending on what those triggers are. And, some people were getting screen as a trigger. So we're working on definitely building their tolerance to screens, but we're also looking, can we print things off? Can we adjust lighting? Can we just decrease some of those triggers? So we definitely look at that.
Okay, we have a question from Adriana. She says, what if a client with PCC exhausts all their energy just getting to your clinic? Do you offer virtual care for those who are unable to attend in-person treatment?
We sure do. And yeah.
Typically for the intake, we can't do it virtually though. So for the initial assessments, it's something that you can't really do an appropriate assessment for safety to give appropriate recommendations without the patient coming into the clinic. But we'll do follow-up treatment as a virtual treatment. But it's something for us to ensure safety of the patient and the ongoing care. That the first appointment is generally in person, and then it moves towards virtual if that's what needs to occur.
Yeah, that's a good point.
Great, thank you. Anne, I can see you've raised your hand. If we go to Anne first for the question, and I'll come back to the chat to go through more questions.
Yeah, it's just a comment about telerehab. In Quebec, some physiotherapists have developed an approach. So, of course, there's an evaluation before to see if it can be deemed secure to do telerehab for the whole process, including the first visit, because some people do not have risk factors, which is appropriate to do. And it's very interesting how they work it up and how much they can help. Because yes, many people cannot. I, for myself, could not get there. It would be more than I can do. So, and it's very interesting how they're doing it. It's the Cure. I'll write down the name of the clinic in the chat.
Awesome. Thank you, Anne.
Thank you, Anne. We have a question from Lindsay. What does a realistic return to work look like for these patients? You mentioned in your brain fog presentation, how fast are you seeing improvement in these patients?
All over the map. I wish I could give an answer to that, but it is, when you've met one person with PCC, you've met one person with PCC. So although we see trends of things with symptoms, the response to treatment is all over the map. Sometimes we see people and we're ready to start a return to work quite quickly. And other people, it's very, very slow. And, and some people, might not be able to go back to work. It's literally all over the map. So that's it. There's way too much variation in that to be able to give a good answer.
Yeah, the most important piece has generally been it needs to be something that's individualized for each individual patient. There's no cookie cutter in this. This is very much each as a case by case based situation, and typically insurers hate us for that.
Yeah, and I would say, and please correct me if I'm wrong from you too, is that what we've seen is that the more consistent that we can be with the client, the better our outcomes have been. When people aren't able to be consistent, and not to people's fault of their own, but that might be finances or location or just life, right? Is the worse the outcome. So the more consistent we can have people in rehab, the better they're able to. And I know, and I do appreciate when people are like, yeah, I can't even get there. That would take too much out of me. But the people that we actually can get through the doors and start, and even if that's starting so minuscule that you're wondering why you got there, those are the people that we're able to see better progress with.
A high portion of patients typically find that because the intake for our program is a physiotherapy assessment, and then we refer out, or then I refer out to Lindsay and to Sophia and into those other things. So they usually end up doing a 1 hour at least or assessments a week for 2 or 3 weeks. Typically, most people end up worse off the start with starting that and we recognize that for it, and it's not something that's purposely done to make it more challenging. It's done with safety in mind and making sure that we can present a consistent approach and individualize everything so that we're working together and being able to do things appropriately.
Thank you. We have a question here from Lorraine. She says, most informed about PCC who treat patients are clear we have gumption in spades. How do you tamp down the drive to accomplish things to avoid triggering PEM? It's the opposite of encouraging people to do more.
Right? Yeah, exactly. I agree. It's like, it's sometimes I take my mom voice out. Oh, why? And people laugh. I get really good. We develop really good rapport with our clients here, and I'm like, why would you do that? And they're like, I know. When I was in the middle of doing it, I thought Lindsay's not gonna approve of this, and she's like, and it was true. And I mean, we know that people also have to live and have lives and can't just cancel everything for the next 2 years of their life or whatever. So recognizing that. So we do try to plan around important, valuable outings versus say, oh no, you can't do that because that means you won't be able to come to rehab next week, right? We just make plans around that. But yes, you're right that that drawing back is a really hard thing. Yeah.
And like what I usually word patients when they're kind of starting is scheduling is the most important part of getting started. And that's why journaling and scheduling are the two most important parts of getting started with a program like this, because we need to know how you're going to respond, and quite often people don't know how they're going to respond to an individual task, and the journaling and the scheduling allows it to be something that we can make those adjustments and make those changes so that it is something that we can be a build up instead of just a draw of energy.
Carrie has a question. Does your clinic do out of province, or is it just within Saskatchewan?
I'm not under physiotherapy licenses. I'm not able to do outside of Saskatchewan.
Yeah, me neither. I don't. So how it works with my license is I would need permission. Either permission, so for example, say someone was in Manitoba, I would need permission from the Manitoba licensing body to see that person virtually out of Saskatchewan. And so sometimes you might have to register for a license under the other province, but other times the other province could give you just an exemption to treat that person virtually. But yeah, because if you're treating them, then they're in another province, you need to have a regulatory body to cover you for that treatment.
Yeah.
I'm not sure about,
It's national, so within Canada, for exercise physiology.
I'm just going through the chat here to see if I've missed anything. I do see there's some talk going on about insurers. There's a comment here about, we hear a lot of stories about people becoming severely disabled by complying with the rehab requirements of LTD WCB insurers. So there's a lot of talk going on about insurers in here.
Yeah, we've had people come here too that have had similar experiences where they kind of feel like it was just like they felt like they were part of maybe a cookie cutter type program of return to work, and they felt like they were like their words would be like blown up. And we've had that experience. I'm not gonna say that we've never blown anyone up, but we try really, really hard to not, and we try really hard to understand the individualized approach that's necessary.
Great. Kathy, I see you've raised your hand. You can unmute and ask your question.
Yeah. Does workers' comp and the disability insurance plans out there, like, are they getting education about PEM at all? Like, is anybody going to them and saying, like, stop being idiots? I mean, like I had long COVID and was off work for 2 years and was made to do this really extensive workout program that would wipe me out. On my very last day of the program, I did the regular program, and then they made me do a test. And well, I was wiped out from doing the program. And then they basically told me I was lying and cut me off my benefits because they said I basically cheated on that final test because I couldn't do it. And like, these disability programs and WCB really need to be educated about this, because this is very different from anything else that goes on out there. And I know I've been affected by it. How many others have been affected by all of this? Makes me very frustrated.
I'm sorry to hear your experience, Kathy. I think we've experienced that with other health conditions as well. We see things like this with concussions and other chronic illnesses as well, where we're really working to try to educate people in our own ways through case conferencing and things like that. And gosh, I hope people in positions bigger than us that have more say are working on this too. You know, we hear you, and yeah. And I hope that I hope more advocacy groups and things like that can definitely help with that.
Yeah, there's a comment here from Lorraine Graves. She says, thank you for today's talk. There is such a gap between what you know and what most medical and insurers know. That gap is harming so many people, plus costing the healthcare system and insurers more money.
Yeah.
And I can see you've raised your hand. You can unmute.
Sorry, I hope I'm not cutting out. I just wanted to make a general comment and really appreciative of that presentation today. I'm a physician, as well as having long COVID for more than 4 years now. One thing I moved completely away from when I explain and discuss PEM with clinicians is I totally moved away from exercise or no exercise. I often use the energy envelope theory, meaning you have some sort of a envelope of energy for your day, which will be used to do everything you do, whether cognitive, physical, or emotional. And that means exercise might work one day, and if you have more cognitive on another day, exercise might not work. So it's not about doing exercise or not doing exercise. It's staying into your envelope and below your PEM threshold. Of course, I mean, this whole thing is for people having PEMS. And for clinicians I've talked to, it seemed clearer for one thing. And also it sort of puts aside the problematic discussion around exercise or no exercise. And it's very understandable that the community, the ME community, has been traumatized by so many rehab approaches around exercise. It's totally understandable that the word exercise itself is problematic, and it is how it is used most of the time. But going around the energy envelope and moving away from the exercise or no exercise, I think has been helping me inform clinicians. So I just wanted to make that general comment.
I haven't heard of the energy envelope one, but or at least I use a strategy called spoon theory, which is kind of based from more so MS research. I found more people have heard of spoon theory, and I can use that as the conversation piece for people, because they at least recognize what spoon theory means. It's from your description, it sounds like a very similar thought process, and that, because like your description of it is near exactly what I at least use for my discussion with patients on that exact topic. So
yeah, I have both references. I have the reference from the spoon theory, which comes from a patient actually who described how her thing happened. I don't know, but with the time, if I can pull up a reference for that energy envelope, it's from Jesse Leonard, who's been working for decades on ME. So I'll try and fetch a reference on the energy envelope theory. But yes, it does resemble. It's a bit different, but it does resemble, yes.
Thank you. And we have another question here from Zahra Kenji. What examples of parameters do you use to help clients track and manage their energy levels when scheduling activities?
I use a notepad and a piece of paper. And I don't get too complicated, and we kind of figure out together what works for each person. Some people have lots of details and go into in depth, and other actually, I have a client. I wish I had it with me, because I'd asked her if I could share it, but I don't. And she might even be in service. But she made her own like her kind of scale of what 0 to 10 was, and she kind of described it to like, yeah, I feel great. The same thing as like my old self to like good for COVID, and she has this whole scale, but really it's just kind of however people want. And they kind of let me know what their scale is. And we just really go with really almost like bullet journaling, and then assign a number to like, I had a shower, I slept, like that kind of thing, and what their energy level was.
We might be able to fit in 1 or 2 more questions here. We have a question from Angela. My IM physician told me I must exercise 20 minutes per day regardless of symptoms in order to recover from ME CFS. I haven't been doing that because I'm struggling to get through my ADLs without crashing. What are your opinions on this?
As we talked about the spoon theory or that energy envelope, working within that and scheduling it appropriately throughout your week would probably be more beneficial and would help you receive the benefits of the exercise. And maybe 20 minutes is too much for you. Of course, that's individual, but yeah, working with your day-to-day symptoms and in terms of your weekly schedule to support adding in some activity.
Thank you so much, Sophia, Lindsay, and Derek. Thank you. I'm just going to run through the slides here and the final slides. And if we have a little bit more time, I'll see if there's a few more questions. So I'll just share my screen now. So yeah, thank you everyone for your questions. Please check out the CAN-PCC Patients Resources page, where you can find more information about my guide, infographics, and upcoming webinars. You can also check out the resources for health professionals, where you can find information about upcoming webinars, an online CPD course, and EBM Connect Canada. And thank you again, everyone, for attending, our speakers and everyone who joined this webinar. Please complete the survey if you can by scanning the QR code or by clicking on the link in the chat, which I posted before. And please sign up for the CAN-PCC newsletter or visit their website for more information about the national guidelines. You can also register for more PCC webinars in this winter 2025 series, and the webinar recordings will be available on the CME PCC website once the captions have been translated to French. And all of these links are available in the chat. So thank you again, everyone. If there are any questions in the chat that we didn't address, we will make sure to go through them and respond to them after this webinar via email. Thank you, everyone. Have a great day. Thank you, Sophia, Lindsay, and Derek.
Thank you.